Good afternoon, everyone. My name is Nader Kamangar. I'm joined here today by Dr. Robert Su, who's the professor of radiology at UCLA, as well as the residency program director for the radiology residency at UCLA, as well as the director of interventional radiology there. This is an interactive session, so there are embedded questions that you're going to see, and we're going to be asking for you to actually use the audience response system as we go through these questions that will lead up to specific areas that Dr. Su will be highlighting. So please make sure when we get there to all vote. So without further ado, Rob?
Great. All right. Thank you all for coming. Thank you, Nader. All right, so okay, so when looking at a high-resolution CT, it's really important to keep the pathology-based terms clear and distinct compared to the pattern-based terms. So the pathology-based terms are really what's reflected on pathology. So these are going to be entities like UIP, NSIP, LIP, AIP, organizing pneumonia, desquamative interstitial pneumonia, respiratory bronchiolitis, interstitial lung disease, and Langerhans cell histiocytosis and lymphangioliomyomatosis. The pattern-based terms, on the other hand, are kind of a bird's eye or airplane view of what's happening at the pathology level, or what we're seeing on CT. It's just a reflection of what's happening on the pathology. So these terms are going to be a little bit vague, but for lack of better, these are kind of descriptive findings, such as reticulations, nodules, cysts. And there may be some terms like heterogeneous attenuation, so that there's alteration in the lung parenchyma. And you'll see terms, and we'll go over this, mosaic attenuation, airspace attenuation, or consolidation. And this can be in the form of heavy ground glass or just ground glass, and true airspace consolidation, where you can't see the underlying lung structures. So the patterns that we're going to discuss this afternoon are simply reticulations, nodules, cysts, and airspace disease, and some of the common entities that display these sort of radiographic patterns. So under reticulations, you have mostly the interstitial lung diseases, UIP, NSIP, chronic hypersensitivity pneumonitis, the nodules pattern or the nodular pattern, and we'll go through a number of these patterns, but clinical entities would be sarcoidosis, metastases, more of the airway-borne things like subacute hypersensitivity pneumonitis, cysts, as we kind of mentioned, those two entities, and airspace or predominant airspace disease in the form of organizing pneumonia and DIP.
So our first case is a 77-year-old man with a 3-year history of progressive dyspnea on exertion. The cases are intentionally kept brief so we can get through more. So you're going to see a few axial images. And a coronal there.
And then I'll go back through them.
So what is the most likely diagnosis here? Is this NSIP, asbestosis, idiopathic pulmonary fibrosis, or chronic hypersensitivity pneumonitis? Please vote. Great, 94. So you guys all have this down. I would just
Session's over.
Yeah. I think just although only 1% selected it, just to recognize that asbestosis could have very similar features. I mean, what are we seeing here? The predominant features we saw here is a reticular pattern that is more lower lung field peripheral predominance with reticulations, honeycomb changes, traction bronchiectasis and bronchiolectasis, and minimal amount of ground glass, asbestosis would not be inappropriate here if there were other features of asbestos-related lung disease like pleural plaques, rounded atelectasis, and a clear history. So that's the only other answer that could make sense with the appropriate additional findings.
Okay, so obviously we're in the first sort of gamut, which is reticulations. And again, we talked about, briefly mentioned UIP, NSIP, chronic HP, and the clinical entities that this may represent, IPF, collagen vascular disease, drug toxicity, or maybe in some cases asbestosis, or diseases that might give you reticulations. So when dealing with reticulations, it's important to look at the differentiating features. And so you'd like to know what the distribution of those reticulations are. Is it upper versus lower, central versus peripheral, segmental versus diffuse? Is it the pattern that you're seeing a heterogeneous pattern? Is it a more homogeneous pattern? When you compare right and left sides, do they kind of overlay or mirror one another, or are they very different? You also want to look for honeycombing, subpleural sparing, ground glass attenuation. And there may be some other clues on the film that give you maybe some idea or maybe a cue as to what the patient might have in terms of ancillary findings. So with asbestosis or asbestos exposure, you might look for pleural plaques. You might see arthropathy or dilated esophagus in some of the connective tissue diseases, as well as subcutaneous calcifications. In the setting of amiodarone toxicity, there may be a hyperdense liver or thyroid. And certainly, history is hugely important to help narrow the differential diagnosis or at least figure out what the pattern may be representing. So as you all know, UIP pathologically is characterized by temporal and spatial heterogeneity, and it's the characteristic or most distinctive feature here is the fibrogenic foci. Now, the CT features, the most common things that you'll see are going to be peripheral reticulation with a basilar predominance and honeycombing, if you see it, and you see it in generally 60 to 70% of the cases. There is not too much consolidation, but again, lower lung predominance, right? So here's just an example of a classic case of UIP, and this sort of classic presentation, or what we call consistent with UIP pattern, is seen in about 50% of patients. So here we see from top to bottom, you can see that the disease is predominantly subpleural, predominantly basilar. It's characterized by lines, reticulations, and certainly there's a huge degree of honeycombing. And honeycombing, if there's nothing else that you take away from this session, is that honeycombing is characterized by, again, these sort of thick-walled, polygonal, hexagonal structures, but within the actual area or the center of that is air density, not gray lung, but really black air density that's similar to the air that's, for instance, within the trachea or the larger bronchi. And that's really the true definition of radiographic honeycombing. So here we see just some additional images. And again, these are true honeycomb cysts. Again, very thick sort of inter and intralobular septa, irregular, and within the center of that area is clear air density, not more gray density of lung. And here we see the histopathology that goes along it. Again, the thickened septa. We see the fibrogenic foci and the honeycombing. And again, the gross specimen that the CT images reflect. Here's kind of the natural progression of what we see in IPF, UIP. And again, this is over 2 years, so it's a sort of a slow but stepwise deterioration over time. You see areas of coarse ground glass and reticulation ultimately becoming honeycombs, and with increasing architectural distortion and traction bronchiectasis and bronchiolectasis. So in 2009, Song looked at or tried to compare those patients with connective tissue or collagen vascular disease, UIP, versus those with idiopathic pulmonary fibrosis. They looked at 100 patients and found that the ones with UIP with collagen vascular disease largely were younger, women and non-smokers, and was associated with better survival. They had less fibrogenic foci, less honeycombing and honeycombing spaces, but had more germinal centers and inflammation, and they coined the term atypical UIP without honeycombing. The germinal center score was the best discriminative factor of distinguishing these two diseases, and age, total lung capacity, and honeycombing were independent sort of prognostic factors for improved survival. So here we just have a couple cases. All are path-proven UIP. And here we see a person with a dilated esophagus, and again, this is what I mean by looking at these ancillary findings for clues, but you see, again, a basal or predominant disease, reticulation, and honeycombing, and with a dilated esophagus, this was diagnosed as scleroderma. On your right, on the top, we see another patient with UIP, but notice, again, you see the dilated esophagus, but not quite the honeycombing, and you see a lot more ground glass in this case. And so again, not your classic UIP pattern, and the degree of ground glass may make you think it's something altogether different than UIP, but again, this turned out to be scleroderma lung disease with UIP. On the bottom, we see more ground glass attenuation, and you see that there's a lot more ground glass than the reticulation that we see here. And again, it is a subpleural predominant disease, and not much honeycombing, as you can see. And on the soft tissue windows, look what you see, a little pericardial effusion, and you see soft tissue calcification. So this is a patient with dermatomyositis, with lung disease, again, path-proven UIP. So the UIP that we see with collagen vascular disease may be somewhat different, or it often is very different than the UIP that we see with IPF. So let's look at some of these sort of more unusual features of UIP, IPF. So sometimes you'll see a ground glass predominance, as you see in this top image here. Again, the ground glass is a lot more than the reticulation, or outweighs the reticulation. There may be asymmetric involvement on this bottom image. You see that the left lung is more considerably involved than the right, and there's not so symmetric. You might see areas of focal air trapping, which again is not uncommon but unusual for UIP, IPF. You may see areas of pulmonary ossification, and so I don't know if it projects very well, but you see little hyperdense nodules within the densest areas of fibrosis on the bottom image, and these correspond to areas of pulmonary ossification. And these are the fibroblasts undergoing metaplasia from chronic inflammation to become osteoblasts and laying down bone. In 90% or more, depending on which series you look at, those patients with IPF, UIP have what we call small to medium-sized lymph nodes, and so these are diameters, short axis of 1 to 2 centimeters, and again, it's a reactive phenomenon. And in about 10 to 15% of patients with IPF, you have an accelerated deterioration or exacerbation. So here's a case that had just pretty much reticulations on the initial or baseline CT, but during the exacerbation, you can see an extreme amount of ground glass that has come about involving all lobes and almost all portions of the lung. This was a case of sort of AIP on top of the UIP that happened. Here we see sometimes when you're dealing with patients with very diffuse lung disease, common diseases are sometimes very difficult to tease out. And in this situation, the only clue as to the diagnosis here is if the sort of astute observation of small symmetric pleural effusions that you can see. And this was a case of somebody with idiopathic pulmonary fibrosis with a congestive heart failure exacerbation represented by the pleural effusions and small pericardial effusion. These patients, as you all know, are susceptible to infection. Here on the top image, we see a necrotizing pneumonia with a bronchopleural fistula and a pneumothorax, air fluid level within the destroyed lung. On the other side, in the left apex, you see a mycetoma. You see a more classic kind of consolidative pneumonia in this bottom patient, in the right middle lobe and in the left lower lobe. And as you all know, these patients are susceptible to lung cancer. And here's the same patient, a more superior image. You see a spiculated nodule in the left upper lobe, as well as one in the left lower lobe. This was a case of synchronous lung cancer in somebody with pulmonary fibrosis. And certainly, you can have air leaks or barotrauma. And so here you've got pneumomediastinum, and you have some a left pneumothorax, as you see in this case down below. That brings us to our next case.
So this is a 42-year-old with a 1-year history of progressive dyspnea with mild exertion as well as a chronic cough.
I just like the bigness of these images, right? Like so many talks, you see little images.
So what do you guys think? What is the most likely diagnosis here? Is this NSIP, asbestosis, IPF, or chronic HP? Please vote. Outstanding. So 2/3 of you got this right, and that 1/3 I think is not entirely wrong. But what we're seeing here on imaging was a reticular pattern with a considerable amount of ground glass attenuation. The ground glass attenuation and the reticulations, although more lower lung field, were actually very peribronchovascular along the bronchovascular bundles, or the axial interstitium as we call it, with actually some areas of subpleural sparing. There was also some degree of traction bronchiectasis as well as bronchial wall thickening. So chronic hypersensitivity pneumonitis would more often give you a reticular features with areas of mosaic attenuation and air trapping, and that Rob will go over in a bit. But really this was most consistent with NSIP.
Okay, so we're still in the gamut of reticulations, and so we'll talk a little bit about NSIP. So unlike UIP, the pathologic features can be divided into cellular and fibrotic NSIP, and again, unlike UIP, we're going to see a temporally and spatially homogeneous disease with a lot more inflammation without this characteristic fibrogenic foci. There's not too much architectural distortion, and certainly almost no honeycombing. What we see on CT is predominantly ground glass admixed with reticulation of variable severity, and it, in many cases, will spare the subpleural periphery, or the very edge of the lung, in about 66% of cases. And so this is what so here we see, again, we see a more axial disease, meaning the center of the lung is involved, or the center of the lobe. And we see a lot of ground glass, and the ground glass outweighs the degree of reticulation here, right? So what we're seeing is more of this sort of dense gray lung. And what you can see is by subpleural sparing, we mean that the entity comes up to the subpleural lung, but just has a ribbon of where the lung is not involved. And with NSIP, this is probably the most characteristic finding that we see, and we see it in about 66, 65%, depending on what study you look at, of the time. It's predominantly a lower lung disease, and as the fibrosis progresses, you'll see more architectural distortion, you'll see more traction bronchiectasis. Now here's a different case, and here we can again see the ground glass admixed with the reticulation, favoring the lung bases and posterior periphery. But note again that we see kind of that characteristic subpleural sparing. And so if you see this, it's very good for NSIP. if you look at a cellular NSIP case, it's often very steroid responsive because of the intense inflammation associated with this entity. And you can see that after corticosteroids, all that ground glass has pretty much resolved. I mean, there's still some areas. And then there are some more reticulations and coarse pattern, which is the underlying maybe fibrosis that has already ensued. So if you compare this to UIP, they're kind of two ends of the spectrum in terms of looking. NSIP tends to be more soft, homogeneous, it's a little patchier, and again, we have that characteristic subpleural sparing. But on the opposite end of the spectrum, we have IPF UIP, which is coarse, it's a lot of irregular lines, reticulation, and there's honeycombing, right? And rather than the subpleural sparing, the disease comes all the way to the lung edge. And so here we can see some nice characteristic images. Again, ground glass admixed with reticulation, subpleural sparing in SIP. Again, here we see reticulation, basilar predominance, subpleural involvement, and the characteristic honeycombing that we've come to expect with a UIP pattern. Now, just a note about chronic hypersensitivity pneumonitis. This is characterized by what we call very heterogeneous lung on CT. And so we've got areas of ground glass attenuation, reticulation, and then we have these areas of hyperlucent lung or black lung that look to be sort of groups or isolated secondary pulmonary lobules that are hyperexpanded. And ultimately, if you do expiratory imaging, these may, or you wouldn't be surprised if they trap a high degree of air. So this, at TLC, when you see the ground glass reticulation admixed with air trapping, this is what we call the head cheese sign. This can be segmental, the pattern can be segmental, there may be airway thickening because it is an airway process. You certainly will see reticulation. There may be a basilar predominance in about a third of cases. But the extreme lung bases may still be spared. And as you know, there may be some subacute findings depending on the chronic antigen exposure, and most of the time we don't know what antigen has caused this process. So here we see just a different case. Again, we can see quite a bit of ground glass associated with this, admixed with areas of fibrosis and what turns out to be lobular sparing or mosaic attenuation due to air trapping.
So our next case is a 45-year-old African-American male with a 3-month history of cough, dyspnea, and intermittent fevers. So what is the most likely diagnosis here? Is this subacute HP, stage 2 sarcoidosis, silicosis, or miliary TB? Please vote. Great. You guys are right on. This is indeed stage 2 sarcoidosis. What we saw here was a completely different pattern, a micronodular pattern of nodules less than 1 centimeter that are too numerous to count. Moreover, these nodules were really preferentially lining areas that involve the lymphatics, such as the pleura, the fissures, as well as the axial interstitium or the bronchovascular bundles. On the axial views, we saw that the distribution was slightly more preferential to the mid to upper lung zones. And if you paid some more attention to the nodes, you did indeed appreciate that there were, even though these were lung windows, some degree of mediastinal and hilar adenopathy. So this indeed was stage 2 sarcoid.
All right, so as you may have guessed, we're heading into a different gamut of nodules or a nodular pattern. Now, when differentiating nodular pattern of disease, it's really important to understand the structure of the secondary pulmonary lobule. And by that, here we have a unit, the secondary pulmonary lobule. It ranges in size anywhere from 1.5 to 2.5 centimeters. And you see that here's the pleura. You see interlobular septa. And within the interlobular septa, you have the septal vein. And each secondary pulmonary lobule is subtended by a lobular bronchiole and an arteriole, and that has a little bronchial artery, and also there are lymphatics that run all along this, as well as within the septa and along the pleura as well. And so here we see on CT just kind of what that secondary lobule, pulmonary lobule would look like. So when dealing with this nodular pattern, you're trying to figure out what the nodule's relationship to the secondary pulmonary lobule structures are. And that gives you maybe some insight as to what the distribution pattern overall is of where these nodules are caused by or where they're locating. And so what really you want to look at are the relationship of these nodules to the fissures, the pleura, the septa, and make the observation, are these nodules clustered or are they kind of just diffuse and random? And we'll go over this. So if you're dealing with a small sub-centimeter nodular pattern or a lot of them, first question you want to ask yourself, are these nodules on these lymphatic pleural surfaces? Are they on the fissures? Are they on the pleura? Are they on the septa or on the peribronchovascular lymphatics? Next question you want to ask yourself, are these nodules clustered, or are they sort of isolated and you see one at a time? And when you decide on localization, these are the patterns of distribution. So you think of perilymphatic patterns of nodules, random patterns of nodules, centrolobular, meaning it's the center of the secondary pulmonary lobule, or is it more of a small airways pattern? So let's break this open a little bit. If we see most of these nodules congregating in areas that contain lymphatics and pleura, the fissures, the septa, and the pleura, as well as the peribronchovascular lymphatics, if we see that, we're really dealing with a lymphohematogenous process. This could be isolated to just a perilymphatic process, sarcoidosis, silicosis, lymphocytic carcinomatosis, or it may be that it's a random pattern, meaning that, for instance, METs and miliary infection are seeding those lymphatic structures, but they're also going elsewhere within the lung. If we don't see this sort of lymphatic pattern, then we're really dealing with the kind of an inhalational process. So the agent is coming in through the airways. It could be more generalized in a central lobular pattern, meaning it's hitting all sorts of airways at one time, as in the case of smoking-related lung disease, hypersensitivity pneumonitis, or it may just be isolated to the airways and kind of clustered and focal, and in cases of cellular bronchiolitis and panbronchiolitis. Now, if we add the clustering, meaning that these nodules are clustered on surfaces, if they are clustered and we are dealing with the perilymphatic process, you're really talking about sarcoidosis for the most part. And if you see them clustered but not in a perilymphatic way, and none of those surfaces are involved, you're really talking about a small airways process. So in addition to the distribution localization, sometimes the morphology of the nodule is important, the density. How dense is it? Is it small, dense, or soft tissue as opposed to more ground glass? What are the edges like? Are they sharp, ill-defined? And what's the morphology? Are they branching or what we call tree and bud? So let's look at the perilymphatic pattern. And up here you see a diagram. Again, we see the secondary pulmonary lobule, the subtending lobular bronchus, and the artery. And first of all, you notice that these nodules are small and very dense with sharp margins. Next, you know that, look, they're involving all these lymphatic structures that we talked about, the septa, the pleura, the peribronchovascular lymphatics. Now, some would say that you need at least 10% of the nodules going on those surfaces to call it that these surfaces are involved. Others would say greater than 90. And again, you see that they're clustering to the lymphatics. And so really, again, this is characteristic of perilymphatic disease, sarcoidosis, silicosis, and to some degree lymphangitic cancer. So here, again, we see some cases, different case. We see, again, look at where all these sort of well-defined soft tissue nodules are. They're on the fissures, they're on the pleura, and they're on the septa and along the peribronchovascular lymphatics. Here you see the specimen of loosely formed granulomas and interstitial thickening, which is characteristic of sarcoidosis. Here we see in a different patient, again, you see nodules, but you see that the nodules are again on the septa, you see them on the pleural surfaces, the fissures, and along the peribronchovascular lymphatics. So this is a perilymphatic process. First and foremost, you think of sarcoidosis. Here we just have another image. Again, look at the fissures, just beaded with nodules, right? You see septal thickening and nodularity, pleura, and again, some beading of the peribronchovascular lymphatics. Now, here we see a case where you got larger irregular nodules, but that really shouldn't dissuade you from thinking that it may be sarcoidosis, because look at where these nodules are. Again, along the fissures, along the septa, right, and along the peribronchovascular or septal lymphatics. And so again, this is another case of sarcoidosis. Now, with sarcoidosis, sometimes you'll get architectural distortion, meaning that the lay of the land is not quite what it should be, and areas of lung look to be stretched, others sort of distorted and cicatrized, and that's because this is a chronic inflammatory process. You may see this, what we call peribronchovascular beading. And so when we look at the bronchus, the bronchioles and the bronchi, as well as the arteries, they look like they have little nodules or studding along the surface. As that fibrosis sets in with the chronic inflammation, you may see sort of this angulated bronchovasculature because of the distortion and fibrosis associated with it. If you were to look at this patient in maybe three, sort of divided them into thirds in a coronal situation or plane, you can see that characteristic of sarcoid, the apico-posterior segments are the first and most severely involved, and it's a middle third disease here. See that in two different cases. And as you all know, these areas of fibrosis are going to gravitate to the mid and upper lung. And again, coronal, sagittal reformats, as well as chest x-ray, really help you in cases of diffuse disease to see where the concentration or predominant portion of the disease is. And here, in some cases, you might see honeycombing, even in cases of sarcoidosis. Rare presentations or features of sarcoidosis, you may see ground glass attenuation or even airspace attenuation, as is in this case of alveolar sarcoid. You might see septal thickening, as you can see here. Now, a lot of times, if you see a lot of septal thickening, rather than lung infiltration itself, you might want to think of a cardiac involvement of the sarcoid with heart failure. And on some occasion, you can have what we call bullous sarcoidosis. And so this is due to air obstruction and cyst formation, as you can see in this case. And on rare occasions, you may see pleural effusions, but again, that may be in the context of more cardiac sarcoidosis with heart failure.
All right, moving on. 28-year-old male presenting with a 6-week history of fevers, night sweats, non-productive cough, and 25-pound weight loss.
I think every year we say that we want music,
Yeah.
but we forget to do it.
So what is the most likely diagnosis here? Subacute HP, stage 2 sarcoid again, silicosis, or miliary TB? Please vote. Great. The majority of you got this indeed right. This is miliary TB. If you just go back, Rob, we did see nodules that were too numerous to count. They were clearly involving areas lined by lymphatics. We clearly saw fissures were involved. the pleura was involved. But there were also nodules that were not involving those areas, nodules that were kind of randomly dispersed without predilection to the perilymphatic structures, and that's what we call random. And certainly in this case, it would be a hematogenous infection that would work. Hematogenous Mets would be a possibility here. Certainly, usually there would be variation in the sizes, as Rob will point out. Occasionally, papillary thyroid cancer can give you very, very small millet seed nodules, not dissimilar, but often there too there is some variability and not necessarily these millet seed nodules as we see here with hematogenous spread of tuberculosis.
All right, so now we're kind of talking about random nodules and moving away from perilymphatic. And so here again, you can see nodules fairly well defined, well marginated, and carry a little bit of soft tissue density, or at least more than just simple ground glass. Now, again, when you ask this question, are they involving the lymphatic surfaces? Yeah, you have a few on the pleura, you might have a few on the septa, you might have a few along the peribronchovascular lymphatics. But then you have other nodules that, hey, I don't know, they're just kind of floating in space within that secondary pulmonary lobule. And so when you see this sort of kind of distribution involving the perilymphatic surface a bit more, and you can't place some of these nodules, this is what we describe as a random pattern. When you're dealing with random pattern, really you're only dealing with sort of this lymphohematogenous spread of malignancy or infection. So again, clustering, not so much clustering like we saw with the perilymphatic diseases with all the nodules on the lymphatic surfaces or structures. So this is what random looks like. You can certainly see nodules on the pleura. You can even see some nodules lined up along a septa, but other nodules are just kind of thrown out there, and what you have is a fairly homogeneous perfusion. Like if you move your eyes from the lateral part of the lung to the medial part, you kind of see an evenness to this distribution of nodules. So with random distribution, they're fairly uniform. They're not clustered. They may be low or low predominant because if they came in via the bloodstream, it's going to go where the blood flow is the most. They're solid density with sharply defined margins. Now, some of these nodules may share similar size depending on the gradient. So, for instance, if they're all getting to the lower lung by blood flow, sometimes the earliest metastases may be all very similar in size and larger down in the lower lung than in the upper lung. There may be a feeding vessel sign owing to the fact that they're vascular borne. They may cavitate, and if it's, they may involve lymphatics as they sort of take up residence in that area. So when you're dealing with metastases, we're dealing with renal, testicular, thyroid, and melanoma. With miliary infections, we're talking about tuberculosis, but other fungal infections like cocci, histo, and even pneumocystis, and sometimes occasionally viral infections. Again, you see that, again, the lymphatic surfaces are certainly involved, but you see a lot of other nodules that seem to just be floating within the lung parenchyma itself. And here, again, in another case, we see some effusions. But look at all these nodules. I mean, like when you look from the medial lung to the lateral lung or top to bottom, it looks all fairly homogeneous. But the nodules are all over, fairly equal throughout the lung. Now, just a few words about lymphangitic cancer. Again, this is a perilymphatic process. It's characterized by smooth or regular or sometimes even nodular septal thickening. And it's a much more linear disease or a reticular disease than a nodular disease per se. There may be some, frequently there's axial involvement. Generally, there's no architectural distortion because cancer in itself doesn't necessarily scar unless it's been treated. There may be adenopathy in about 30% of cases, maybe pleural effusion. And the entities that we're talking about are the adenocarcinomas, the unknown primary, but certainly lung, breast, colon, and pancreas. And again, compare and contrast what we saw with the other, for instance, the perilymphatic sarcoid. Here it's a much more septal disease. It's more linear. Yes, we see some nodules, but that's really not too much of the feature. And for the most part, you see preservation of the architecture, and the secondary pulmonary lobules are not very distorted. And here we just see another case of lymphangitic cancer. Again, a lot more lines or septal thickening. There are a few nodules here and there, but again, it's a more linear disease. And on the soft tissue windows, you can see the mediastinal and bilateral hilar adenopathy in this case.
So our next case is a 23-year-old female non-smoker with a 3-month history of increasing dyspnea and dry cough. I think that these are a little bit harder to see. That's why we have it magnified here, just to get a better sense of things. So what is the most likely diagnosis here? Is this RB-ILD? Is this subacute HP? Is this pneumocystis jirovecii pneumonia? Or is this pulmonary coccidiomycosis? Please vote. Great. It looks like the top two choices are the ones that are most correct. What we see here are, again, nodules that are too numerous to count. And nodules, if you look carefully, they did not have a perilymphatic distribution. They were actually not involving areas lined by lymphatics. They were not involving the fissures, the pleura. And the morphology of these nodules is very poorly defined or ground glass, and they're rather diffuse. There is no clustering, it's rather diffuse. So this takes us into that inhalational category and that more diffuse involvement that we call a pure centrolobular pattern. And of the two choices, the reason why subacute hypersensitivity pneumonitis, first and foremost, is probably more correct here, is because in that little brief one-liner we did say a non-smoker. Certainly RB-ILD, that occasionally tends to be a little bit more patchy, would be expected in a smoker, whereas subacute HP would be in a non-smoker, as in this case.
Okay, so here we have the secondary pulmonary lobule, and when we call centrolobular, we're talking about something within the center of that secondary pulmonary lobule. And the core, often these things gravitate or surround the core structure, which again consists of a arterial, a bronchial, lymphatics, and a bronchial artery. Now sometimes you'll see, if you know what the cause or how the nodule or the pattern got there, if we really think it's an airway process, we may use the term rather than centrolobular, but call it bronchocentric or bronchialocentric. If we think that it's more hematogenous, as in the case of maybe METs, then we will call it angiocentric and so forth. So centrolobular nodules can be solid, but more often they're going to be this sort of ground glass. Generally they're going to be bigger, maybe 5 millimeters or larger, fluffier looking. They may be branching, and they may be tree and bud, which are these sort of kind of jacks, or they look like jacks. And again, if you impose or superimpose the secondary lobular structures, you see all these nodules are in the center or cluster to the center of that secondary pulmonary lobule. So let's look at this on the diagram that we've been looking at. And here we see, again, a fluffier, less dense nodule, generally bigger in size, less density, ill-marginated or fluffy. Right? You see that none of the perilymphatic structures that we've been talking about are involved by these nodules. The fissures are spared, the septa are spared, the peribronchovascular structures are spared. So there is no perilymphatic or lymphatic structure involvement. There's no clustering, fairly homogeneous within the secondary pulmonary lobule and, for that matter, within the lung itself. So there's no clustering, no lymphatic structure involvement. Brings us into this centrolobular pattern or inhalational pattern, more diffuse things like cigarette smoke causing RB-ILD or antigen exposure to organic agents, most commonly in the form of subacute hypersensitivity pneumonitis. HP can be acute, subacute, chronic, depending on the length of time and exposure. Acute tends to be more ground glass attenuation or even airspace attenuation. As the granulomas form, you might start seeing centrolobular poorly defined nodules. Subacute is much more of the nodular pattern that we see. There may be also air trapping at this point, as you can see here, which are these areas of parenchymal lucency or blacker lung. And then certainly in the chronic phases I've already shown you, you're going to see the fibrosis. Here again we see a more involved case of subacute hypersensitive pneumonitis. Look at these nodules. They're ground glass. They're bigger. They're in the center of the lobules such that you almost see kind of a separation from clusters of nodules because that's the outer part of each of those lobules, right? And with regards to respiratory bronchiolitis, interstitial lung disease, again, this also has a very similar, if not almost identical, centrilobular pattern favoring the upper lobes. There may be also some airway thickening. This is seen exclusively in smokers. And basically, it's a smoker with a symptomatic, who becomes symptomatic with shortness of breath and cough, maybe a mixture of PFTs. And this is what this disease is basically an overproliferation and infiltration of the parenchyma and around the airways with this pigmented macrophages, or the alveolar macrophage. Some people feel, or most people feel, that this is on a spectrum of disease, our respiratory bronchiolitis being the least sort of severe, going all the way to DIP. Here we see again, you can see that there's just a diffuse ground glass pattern. None of the lymphatic surfaces are involved. There's no clustering. And so this is an inhalational process. The two things that should come to mind are subacute hypersensitive pneumonitis and RBILD.
So case 6 is a 63-year-old Japanese female with a 3-month history of chronic cough, weight loss, and subjective fevers. So what is the most likely diagnosis here based on the brief clinical history and the radiographic features? Is this Mycobacterium avium intercellulare or complex? Is it pulmonary TB with associated endobronchial involvement, metastatic bronchogenic cancer, or pulmonary coccidiomycosis? We have to always bring that up. We're in California. Please vote. Okay, there is a little bit of a spread here, and let's just quickly go over this. What we saw here were a number of features. There were macronodules that were cavitating, and they were thick-walled cavities there. And then there were also adjacent micronodules that had a patchy distribution that were clearly centrilobular. They were not involving areas lined by lymphatics, and they had a Y-shaped or tree and bud morphology. That constellation here really makes TB with endobronchial spread more likely. Now, the endobronchial or cellular infiltrates can be a feature of MAC, but with MAC you'd often expect more localized disease, more bronchiectasis. The macronodules here is really what points to this perhaps being TB with endobronchial involvement causing those micronodules that are tree and bud and patchy in distribution.
Okay, so we're kind of moving on to small airways disease, and the small airways are those without cartilage, and these are generally 2 millimeters or less, and they represent bronchioles, or in some cases very small bronchi. And so the bronchioles that we're talking about are the membranous, terminal, and respiratory bronchioles, and this has sort of changed over the years with better CTs, and we can probably resolve these bronchioles even maybe 1 centimeter from the pleural edge. So the direct signs of small airway disease are going to be the things that involve the small airways. And so, again, we talked about ground glass nodules. We see branching nodules. We see what we call tree and bud, or the sort of jack sort of shaped nodules. And we may, as the process becomes more chronic, we may even see bronchiolectasis, or dilation of those very peripheral small airways. And so these are all forms of sort of direct signs of airway involvement. Now, if we go back to our diagram, we see that, again, unlike the centrilobular pattern of nodules, we see that, again, these nodules still are going to be air-spaced or maybe ground glass, or but maybe overall carry slightly more density. They are clustered, but not necessarily on a lymphatic surface, but within the secondary lobule itself. And so here again, we don't have any perilymphatic or lymphatic structure involvement. They're clustered, not very dissimilar to the more ground glass centrilobular pattern that I showed you just before this. So when we see this clustered pattern, centrilobular nodules, we're really focusing on the small airways process. And this is generally going to be a cellular bronchiolitis, of which most commonly is going to be an infection, or panbronchiolitis. So here again we see, notice that we see the clustered nodules here isolated to the center of the secondary pulmonary lobule. You don't see any sort of nodules on the lymphatic surfaces or structures, and you see that it's kind of patchy. It's not all the way throughout the lung. It's sort of isolated to this area, that area, other areas. And what's maybe helpful if you see it is that maybe the airways that are subtending that area are maybe thickened as well, indicating or indicative of an airway process. Here we see just a little bit more involvement. We see, again, these sort of little denser nodules. Some are kind of ground glass, little fluffy. Some have a tree and bud look to it. We see that, again, the lung is not homogeneously sort of involved with these nodules, and none of the lymphatic structures are. We also see more centrally that the airways are quite thick. Again, suggestive that this may be an airway process, which indeed it is. And we also see a little hyperinflation, which may indicate air trapping. So panbronchiolitis is seen in Asians, mostly Japanese. It's a diffuse pattern or cellular bronchiolitis. They can get colonized with Pseudomonas. It's accompanied by pancytositis. With HRCT, we see small centrilobular nodules in a tree and bud fashion often. And again, as the disease progresses, we see more large airway involvement. In the later phases, we may see cysts, bullae, and air trapping. Here we see 2 cases of panbronchiolitis. Again, you see, first and foremost, you see dilated airways with thickening, and then you see small clustered nodules, tree and bud, again, within the lung or in the center or central portions of the secondary pulmonary lobules, but none on the lymphatic surfaces. And again, it's a patchy disease, not like an inhalational process where it's much more homogeneous. So there are some indirect signs of small airways disease, and you may come across the term mosaic attenuation. And mosaic attenuation is when you see hyperlucent and hypolucent lung or gray lung sort of juxtaposed to against one another, and they're in a geometric fashion corresponding to either isolated or clusters of secondary pulmonary lobules. So here we see gray lung and black lung simply, and again, it's a very geographic pattern, and you can kind of imagine that these areas correspond to clusters of those secondary pulmonary lobules. Now, when we see this pattern on inspiratory CT, we ascribe the term mosaic attenuation. Now, the other thing that you want to take note is that the dark areas often are devoid of vasculature or small, or they're attenuated or smaller in caliber, and that's because these areas are generally going to be perhaps air trapping or obliterated, and they're shunting blood to the more gray areas of lung. Now, on expiration, when this pattern becomes much more pronounced, meaning that the gray and the black lung become much more obvious, and you can see a more obvious gradient, on expiration, that's what we call air trapping, okay? So if you see mosaic attenuation, these are the 3 things that you think of. It's an obliterative small airways process, obliterative vascular process, or maybe you just have an infiltrative process in the lung that fortuitously is giving you this pattern, okay? And I'll show you, again, you want to analyze it a little further, and if those areas of very black lung have very small or sparse vessels, then you can kind of take this process out for the most part, and really it comes down to one of these two things. And the way that you differentiate between obstructive small airways versus an obliterative vascular process is, you guessed it, to do the expiratory imaging. So what does normal expiration look like? And here we have a patient on inspiration and expiration, and so as the patient expires, the lung becomes grayer. And it becomes grayer with a dependent gradient, meaning that as you go to the more dependent area, it becomes grayer because of blood flow. And you may have small areas of air trapping, but notice that, again, it's not really very profound, certainly not any more than about 25% of a lobe or even on that one cut, and certainly not a lot of air trapping in the non-dependent lung. So on top you have a normal inspiration and expiration, and down below you have inspiration and expiration in a different patient. Now, first of all, you notice on the image on the lower left, you can see that, wow, there's this crazy mosaic attenuation, right? Now, when we look at the gray lung and the black lung and compare, notice that the black part of the lung has almost no vasculature, right? When you see this, this is really called mosaic hypoperfusion, and what you're thinking here is not of an infiltrative process, but first and foremost, obliterative small airways disease or a obliterative vascular process. Now notice on the expiration, right, it almost looks the same, if not the black areas look even more pronounced. The gradient between the black and the gray lung is preserved and even accentuated. And so in this case, this is due to air trapping. Now here's another case. Here we've got on top, we see again, mosaic lung attenuation on inspiration. But notice how the black lung almost has no vasculature, or what the vessels that we see are very attenuated. And so we're really focusing on these two processes. When you do the expiration, that gradient becomes really pronounced. So rather than thinking of vascular causes, you steer yourself to a small airways or air trapping process. Now look at this case. Here we have a patient with large sort of central thromboemboli, and you can see that again there's mosaic oligemia or mosaic attenuation with gray and black lung. The dark lung, the vessels are again attenuated and smaller. But now let's do the expiration. So on top we have the patient with thromboembolic disease. We have the inspiration and expiration. And notice that these black areas become grayer, right? Because they're not holding on to air or not air trapping. And so the hypoperfused lung, because the clot won't let blood perfuse that lung, becomes grayer and can expel air and becomes grayer. And the more hyperperfused lung also becomes grayer, and so that difference between those two areas, or that gradient, does not become more accentuated, okay? Unlike the case we have below. So let's think about it in a sort of cartoon sense. So we'll take the case of air trapping. So here we've got, again, black lung, gray lung, right? So this is on inspiration, and then what do? We have them expire. What happens? Well, the areas that trap air stay black or become blacker, and the areas that are gray, because they're not trapping air and can force the air out, become grayer, so that gradient between the two becomes accentuated. Now let's look at this case of no air trapping and in the case of chronic, in the PE case. So again, we have a little bit of a gradient to begin with, because we've got black lung because it can't get perfused because the PE is in the way or the emboli are in the way. We have gray lung that is hyperperfused or shunted too. Now on expiration, well, there's no obstruction here from the airways, so both can expire air. The hyperperfused area becomes grayer. The underperfused area becomes grayer too. The gradient really doesn't become accentuated. All right.
All right. Case 7 is a 29-year-old African-American male with a 2-year history of progressive dyspnea and cough. Moving on to a different pattern here. Okay. What is the most likely diagnosis? Is this lymphangioliomyomatosis, or LAM, or is this pneumocystis jirovecii, Langerhans cell histiocytosis or granulomatosis, or lymphocytic interstitial pneumonitis? Please vote. All right, so slight majority got this right. I think the key here, this is a cystic lung disease. They're clear, defined cysts. They're walls that are appreciable. Moreover, the intervening lung that separates these cysts was not normal. The unaffected lung actually had slight nodularity and irregularity, and that's really one thing that, as Rob will talk about, will help distinguish a disease like Langerhans cell histiocytosis, where the intervening lung is often nodular because the disease often starts off with nodules that cavitate and then form cysts, versus LAM, where the intervening lung is almost pristine. So really, if you think about those two as being the primary processes in a differential here, you can clearly see that the unaffected lung here, I mean, this is a very advanced case. This patient actually ended up going for heart-lung transplantation because he actually had group 5 pulmonary hypertension from the Langerhans. But nonetheless, the intervening lung was very abnormal here. There was really no normal lung.
Okay, so now we've moved on to the category of cysts, and as Nader mentioned, the two foremost diseases are Langerhans cell lymphangiomyomatosis, but there are other cystic diseases that we'll talk about. So cysts are round parenchymal molucencies, usually thin wall, typically containing air, but sometimes they can contain fluid or even soft tissue. Cavities develop within sort of nodules or areas of consolidation. So when you're dealing with predominantly a cystic pattern, then again, there are some questions you like to sort of ask yourself. First of all, is there a perceptible wall to these cysts? Yes or no? And what is the relationship of this cyst to the central lobular core structure that we talked about? Does it look like the core structures, or like the arterial, the bronchial, are going through the center of the cyst? Or does it look like they're sort of embedded and sort of plastered against the wall of the cyst? As Nader mentioned, you also want to see or look for nodules, yes or no? And is there an upper, lower lung predominance of these cysts, if anything? So these are kind of the questions that you like to ask. And when you're dealing with cystic lung disease, these are probably the most probably the first four most common. Central lobular emphysema by far, Langerhans cell lymphangiomyomatosis, lymphocytic interstitial pneumonia, and the Burt-Hogg-Dubé. I know we kind of always talk about it, but we don't see it that often. So let's look at the case of central lobular emphysema. So first of all, here we see kind of in a mid cut here, we see these little holes in the lung throughout. And the first question you ask yourself is there a perceptible wall? I think you can pretty much see that although you see the cysts, you don't really see a wall around them. That's very obvious. And when you ask your next question, what's the relationship with the core? And again, you look at some of these, and it looks like the central lobular core structures are going right through the center. And I have some better images of this, but look at this. Looks like that structure is going right through the middle of the cyst, and that's because these cysts are clustering around it. There's obviously no nodules, and it's favoring the upper lung. We're talking about central lobular emphysema. So this is what I meant about this core structure going right through what it looks to be going through the center of that cyst. And again, that's because the lung destruction is occurring all around the core structure, affecting the respiratory bronchioles in the center of the secondary pulmonary lobule. So let's look at, for instance, compare and contrast with LAM. Okay, so here again we see cysts, right? Dark little air-containing foci. But the difference when you compare that to emphysema is that all of these cysts have a little bit of a wall, right? 1 to 2 millimeters. And if you look closely, the core structure looks like most of these cysts don't have anything seeming like they're running through the middle of it. And if you look at the core structures, they look like they're embedded or plastered within the wall itself. certainly no nodules, and again, and I don't show you all the images, but I guarantee that this is a more diffuse process. This is lymphangioliomyomatosis. So as you know, this occurs in women of childbearing age. In 30% of these cases, you can have renal angiomyolipomas. And what this represents is an abnormal proliferation of smooth muscle affecting the peribronchovascular structures. If it's affecting the airway, it causes obstruction and cyst formation. If it's affecting the lymphatics, you get chylous pleural effusions in almost in as much as 3/4 of those patients. Again, here you can see the gross specimen that kind of goes along with the CT. You can see that the cysts are going to be numerous, they're thin-walled, and in between those cysts, unlike Langerhans cell, you have fairly normal intervening lung. You may see nodules, but that's so exceedingly rare that you almost never see that. And because it's a cystic lung disease, in 30 to 40% of these cases, the presenting sign may be a pneumothorax. And here we see just a number of different patients with LAM of varying severity. And you can see that, again, look at that. The cyst and the core structure looks like it's embedded in the wall. You don't see any of these cysts have something going through the center of them, and they all have a thin perceptible wall, normal intervening lung, no really zonal predilection for these cysts, but fairly diffuse. And these are cases of LAM. So tuberous sclerosis can also give you cystic pulmonary disease that's identical to LAM, with the exception of the chylous pleural effusions. The triad, as you all know, associations or other sort of ectodermal issues, angiomyolipomas, cardiac rhabdomyomas, retinal phacomas, osteomas, and subungual fibromas. And again, when you look at the lung disease pattern, it looks identical to LAM. All right, so moving on to the next entity, we're going to talk about a little bit about Langerhans cell. And again, you ask your question, you see the cysts, so you ask your question, do I see walls on these cysts? And I think everybody can certainly see walls on these cysts, right? And then you look at the core structure and the relationship to the cysts. And again, you don't see anything really going through the heart of the cyst or the center of the cyst, right? It looks like the core structures are all, again, plastered or embedded in the wall of the cyst. And here, I don't show you too many nodules, but this entity certainly has a much more predominance of nodules than certainly LAM. So this goes through stages, starts with a bronchocentric or centrilobular nodule. That nodule grows and cavitates, then becoming what we call these thin-walled bizarre cysts. These cysts may coalesce, and you get areas of pseudoemphysema and fibrobullous disorganization and destruction and intervening fibrosis. In the early stages of disease, you won't have fibrosis, but later on there is. There generally is a sparing of the extreme lung bases as well as the tips of the right middle lobe and lingula. And again, here we can see just how many nodules. These are all small little nodules, and you can start seeing down on below some of these nodules starting to cavitate and become cysts. And as the disease progresses, you can see, again, more fibrobullous changes, more extensive cysts. Look at the intervening lung is just highly abnormal, and then you get sort of this fibrobullous disorganization in the most severe cases. Okay, moving on to cystic LIP. You see, again, cysts, maybe not so numerous, with a perceptible wall. With regards to the association with the core structure, you may see some cysts with things going through the center, as I'll show you, or embedded in the wall. There may or may not be any nodules, and localization is usually just kind of scattered cysts as opposed to the more diffuse proliferation of cysts as we've seen. So at least Jacot looked at the radiographic features of LIP, found that ground glass attenuation was the most common and that was tied with centrilobular nodules in almost all of their cases. They sometimes see perilymphatic nodules in a high number of cases because this is kind of a lymphocytic or lymphocyte process. And that's what you see, these small little ground glass centrilobular nodules. And here again you see more lymphatic base nodules in another case, and maybe some septal thickening, indicating a lymphatic process. And here we see the kind of cyst that we're talking about in about almost 70% of cases. Again, you see a wall that's perceptible. And in some of these cases, you can see that kind of the structures are against the wall. And here, you can see the core structure kind of in the center with a number of cysts sort of clustering around it. And so with LIP cysts, or the cystic variant, these cysts generally tend to be 3 centimeters or less. Sometimes they're this multiloculated or lobulated or multiseptated cysts. And generally, you can count them. They're not so many and numerous as in the other cases of cystic lung disease that I've showed you. And collectively, they may only have 10% or less lung involvement of these cysts.
Case 8 is a 53-year-old female with a 1-month history of persistent non-productive cough, dyspnea with exertion, and some weight loss. So what is the most likely diagnosis here? Is this MAI, acute interstitial pneumonia, metastatic bronchogenic carcinoma, or organizing pneumonia? Please vote. Great. So we've moved on here to the last category, which is airspace disease. And as we see here, we saw airspace disease that was mostly bronchocentric as well as peripheral. We had areas of patchy airspace disease along with bronchial wall thickening. There was also some areas that you could vaguely say there was maybe a reverse halo sign or atoll sign that was, it's only found in about 20% or so of patients with organizing pneumonia. But clearly, this is an airspace disease, and as Rob will talk about here, clinical history is really important when you're dealing with airspace disease because the differential is often very broad.
Okay, so again, these are some of the other entities that we see that's predominantly characterized by airspace disease, acute and chronic eosinophilic pneumonia, acute interstitial pneumonia, and diffuse alveolar damage, and pulmonary alveolar proteinosis. So with organizing pneumonia, the pathology is patchy organizing pneumonia with intraluminal fibrosis involving the bronchioles and air spaces. And there's often these sort of endoluminal granulation tissue polyps or mesome bodies. And there may be some interstitial infiltrates or inflammation associated with this as well. This sort of honeycombing architectural distortion associated with fibrosis is not very common with organizing pneumonia. The CT features are predominantly consolidation with a lower lung predominance. Sometimes there may be ground glass opacities. And the distribution, again, within the lobe itself is going to be subpleural and sort of peribronchovascular. So it's a combination. Other less common features, you might see bronchial dilation. You may see a non-septal linear or reticular pattern. There may be more obvious nodules and masses in 15% of cases. And overall, as you know, fibrosis is fairly uncommon, and certainly honeycombing is not a feature of this disease. So here we see some of the common things. Here we see a consolidation, airspace attenuation. We see that after treatment, there's a little residual ground glass that ultimately probably will resolve. And here we see more extensive ground glass in a different patient. We see the bronchial dilation in the areas of heavy involvement and even a little peribronchial thickening, which is not unusual. In this bottom case, we see more reticular pattern. Yes, there's ground glass, but you see a lot of lines here, and this is what we call kind of the non-septal reticular opacities. In this pattern here, you can see that the ground glass or the sort of thickening is confined to the edges of the secondary pulmonary lobule. And this is what we refer to as a perilobular pattern. And this is seen, at least in one article, 57% of the cases of organizing pneumonia here. And again, if you think back to that diagram I showed you with all the secondary pulmonary lobules, you can see almost make them all out here. The only difference of the septa being, rather than the septa being thick, it's more kind of consolidation outlining the edges there. There may be, as I said, more obvious nodules and sort of mass-like consolidations in 15% of patients. Again, it's a subpleural peribronchovascular kind of combination. And rarely and uncommonly, you may get to this point where there is actually fibrosis caused by this, this entity. This is what Nader was referring to as the reverse halo sign that you see in almost 20% of patients. So what you have is basically an area of dense consolidation, and within the center of that consolidation, you see ground glass attenuation. And so this is supposedly like an atoll, which is an isle in the ocean, right? And here, just a different case of radiation-induced organizing pneumonia. Again, you see that very dense leading edge, and within the inside of that leading edge, you see ground glass attenuation. Moving on to a little DIP. Again, this is characterized by ground glass opacity that you see here. It often favors the lower lobe, subpleural lung, can be patchy or diffuse, as I've shown you. In 10% of cases, you may see small little cysts here, and that's due to airflow obstruction. And they also may just represent fortuitous or intercurrent emphysema as well. And again, with this entity, you really don't see too often honeycombing. Now, with any airspace disease, you want to try to differentiate the sort of the features and tease them out. Again, looking at the distribution, whether or not there's architectural distortion accompanying lymphadenopathy. If you have it, is this an acute or chronic process, whether it's clinically or radiographically? Has there been a history of treatment response? What's the patient's occupation, immune status? Are they on any new medications or drugs that are associated with lung disease? And ultimately, you may just have to get biopsy results. Here are just some other airspace entities. Here we see a peripheral lung involvement favoring the upper lobes. This is a chronic eosinophilic pneumonia. Here we see, again, more of a kind of ground glass in the right lung, more dense airspace consolidation in the other lung. And this is a case of the mnemonic form of bronchoalveolar cell carcinoma. Here we see these cases are what we call crazy paving, and you may run into this term. And what we mean by crazy paving is that you see ground glass attenuation, and within that area of ground glass, you see this linear pattern of interlobular septal thickening, as well as intralobular septal thickening, resembling sort of pave. Okay, so here again, you see that everywhere you see ground glass, you see the inter and intralobular septa being thick. Crazy paving has been associated with primary alveolar proteinosis, but can be seen in a number of things, and it certainly is not pathognomonic for just PAP, but certainly you can see it in pneumocystis infection, mucinous BAC or adenocarcinoma in situ, that's the mnemonic form, even hydrostatic pulmonary edema, pulmonary hemorrhage, and lipoid pneumonia. So these are kind of the categories that we talked about: reticulations, nodules, cysts, and airspace disease, some of the common entities. Again, when you're dealing with a nodular pattern, and you're dealing with multiple or numerous subcentimeter nodules, first question you want to ask yourself is, are they involving the lymphatic structures? If that's the case, then you're really dealing with a lymphohematogenous process, whether it's perilymphatic or random. If not, you may be dealing with a more inhalational process. Then the next question you want to ask yourself is there any clustering of these nodules? If they are involving lymphatic structures and clustering, you're really talking about perilymphatic processes, primarily sarcoidosis. And if you're dealing with a more inhalational category, then you're dealing with small airways disease. And remember the morphology of the nodules as well. So here, I just put side by side all of the nodular diseases. So again, these are the patterns across the top. The pleural or lymphatic structures, perilymphatic, random, yes, they involve those. Central lobular, small airways, no. The clustering, as we talked about before, perilymphatic and small airways, not so with the random and central lobular. And the morphology of the nodules, perilymphatic, solid, sharp, random, solid, sharp, central lobular. As we get to more inhalational or airway processes, these nodules become more ill-defined, right? Or even branching in tree and bud. The cystic lung diseases that we talked about, emphysema, LAMS, LCH, and LIP, again, you want to ask yourself, is there a perceptible wall? And again, emphysema, no, but the other three entities, yes, as you've seen. What's the relationship with the central lobular core? Is if it looks like it's going right through the center of some of these cysts, that means that the cysts are surrounding that core fairly evenly, and that's what you see with central lobular emphysema. If it's eccentric, you're probably dealing with one of these two entities, and if you have kind of both and these nodules or these cysts are much more finite, you may be dealing with, as is shown here, LIP. Presence of nodules, again, the only two diseases that have nodules, as I've shown you, are LCH and LIP. And localization, emphysema, as you know, is in the upper lung, LAM sort of diffuse with no zonal predilection, LCH sparing the bases, right middle lobe and lingula tips, and LIP, usually, again, a finite number of cysts, representing less than 10% of lung involvement, and they're kind of randomly scattered. Aerospace disease, again, I think history is first and foremost most important. And so that brings us to kind of, we'll ride out with a bunch of quiz questions.
All right. So just no history here. You guys are experts. What is the most likely diagnosis here? Is this UIP, NSIP, metastatic CA, or organizing pneumonia? Outstanding. Clearly, most everyone got it right. The degree of honeycombing that's present here, you would not expect to see honeycomb changes with NSIP. The disease would actually have a rim of subpleural sparing that we don't see here. The disease here goes all the way out to the pleural surfaces. It's very reticular, very coarse, very minimal ground glass. So UIP, as most of you got, is the right answer.
All right, the next case. Go ahead and vote.
Great. So here we had back to a micronodular pattern. Too numerous nodules, too numerous to count. Clearly, the nodules look like they are involving the perilymphatic structures. Moreover, they are clustering along those areas, as Rob talked about. So if you look along the fissures, the pleural surfaces, and the axial interstitium, it looks like it's being riddled by micronodules. So it is a very perilymphatic disease. Moreover, these nodules are clustering in areas lined by lymphatics. So the best answer here would be sarcoidosis.
All right, next case. So on your left is inspiration, on your right, expiration. Same patient.
Fantastic. So there is quite a bit of ground glass, but as Rob talked about earlier, there is this mosaic attenuation that gets exemplified during exploratory scans. So you have these areas of lobular air trapping that is really pathognomonic of with hypersensitivity pneumonitis, in this case, case of subacute HP.
So let me just give you, so these are, the image on your far left is one patient, And the image in the middle and the magnified image are from the same patient, but a different patient. Please vote. Go ahead and vote.
Please vote.
Oh. Yeah.
There you go. All right, a little bit of work to do here. So what we're seeing here are cysts. They're lucencies, but without clearly defined walls. If you really try to draw an outline around these lucencies, it's very difficult. You don't see that thin 1 to 2 millimeter wall. Moreover, if you look carefully in some of the magnified views, you see that the central lobular core, the cyst surrounds that central lobular core, and that is pathognomonic for smoking-related central lobular emphysema. Langerhans cell histiocytosis or granulomatosis, you would actually have a perceptible wall and the central lobular core is eccentric or pushed against the wall, and that is not the case here. So this is central lobular emphysema. How about this?
Go ahead and vote.
All right, so a majority got this right. This is clearly Langerhans. What you're seeing here are clearly defined cysts with perceptible walls. We're seeing two axial cuts, mostly mid and upper lung zones. And what we see is that the intervening lung is slightly abnormal. There are some slight nodularity to the intervening lung outside of the cyst. Moreover, the central lobular core structures look like they're eccentric or pushed up against the wall here. So this would be most consistent with Langerhans cell histiocytosis.
All right, the next case, please go ahead and vote. All from the same patient.
All right, great. 2/3 got this right. What we're seeing here are somewhat ill-defined nodular opacities that do not have a predilection for the perilymphatic structures. Moreover, they're clustering, and in some areas they do, especially on the sagittal and coronal views, have a tree and bud morphology. This is consistent with a cellular bronchiolitis and infectious bronchiolitis, and clearly the differential is pretty broad, would include things such as aspiration, Mycobacterium avium infection, TB with endobronchial spread, particularly if you have a foci like a large cavity, as well as atypical fungal infections such as cocci. So this is an infectious bronchiolitis. How about this case?
Think about the wall of the cyst.
Great. So here, in some ways, this is not too dissimilar from that central lobular emphysema Rob pointed out, with two distinctions. Number one, there is a perceptible wall. You can actually draw a nice outline, whereas with the central lobular emphysema, it was just kind of poorly defined lucencies. Secondly, the central lobular core here, unlike central lobular emphysema, is not in the center. The cyst is not surrounded, but rather it's eccentric or pushed up against the wall. And then what kind of differentiates this from Langerhans is the intervening lung here is pretty pristine. There is no involvement or abnormality of the intervening lung not involved with cysts.
And then the last case is this. So go ahead and vote.
Great way to end the day.
Right.
There you
Wow.
go, 97%. So this is clearly organizing pneumonia. You see areas, airspace opacities that are somewhat patchy, involving the peribronchial vasculature as well as periphery with associated bronchial wall thickening.
All right. Thank you very much. Give yourselves a hand. I think you're the highest correct answer percentage of all the audiences Nader and I have the privilege to teach. Have a good evening.